I just wanted to come on here and talk a little bit about advocacy. I know you guys have probably heard me on and on and on about be your own advocate because no one's going to do it for you. 100% true. I know a lot of people that can testify to that even without Marfan's. But for us, it's so rare that, I guess if you're in bigger cities, you can expect them to, sorry, my hair is really poofy. Anyways, if you're in bigger cities, you can expect your doctors to know more as a rule, right? Well, I'm in West Virginia. So, as I've said before, we're behind the learning curve, and we probably always will be. So, I take it upon myself to, it's a little bit further than advocacy because I try to get any information I possibly can and relay it to my doctor. In a bigger city where you have more people that know about it, you may not have to do that. I'm not sure. But regardless, where you're at in your journey, what your health situation is, you don't have to have Marfan's to be an advocate. You need to be there for yourself, right? You need, when they say, hey, what surgeries have you had? You need to be able to have a list or rattle them off. What medicines? Same thing. What are your illnesses? Same thing. If not, there could be something that is beneficial for them to know and they won't know it. Or if you forget a medicine, they're not going to know it, and then you could have an interaction. So, one thing that I do, I wanted to show you the easiest way that I've found to efficiently be my own advocate. I've done kind of a similar tour in my regular group here. This is my binder. I take this binder or one of my other 10 binders to any doctor appointment I go to. So I kind of just wanted to go over a few things that I have in here that I want you to be aware of and hopefully will help you. Okay? So I always get you don't look like you have Marfan's. Are you sure you have that? You're not tall. You're not skinny. Yes, I'm sure. Most of my stuff is internal. And, they get to know that after the first couple sentences. But I like to have this. I like to have that in my binder because those glasses are what I had when I was aphakic, meaning I didn't have lenses for 11 years. Those are the glasses I had to wear. And that picture is me with those glasses and messed up teeth. And I look a lot more like the stereotypical than I do now. Yes, I have glasses with bifocals, but my teeth are now straight. And my face is long, but it's not too abnormal. I'm not very tall. So this is something for me that I find can be validating. Okay. Also, I'm guessing you guys probably can't see that clearly, so I kind of wrote down a couple things here. That is a list of the stuff that is connected, because how often do you go to the doctor and you say, hey, I have, let's say, joint subluxation, joint dislocation. And they say, well, that's not connected. That's just an example. You can put it on here, and you're going to be correct because you've already researched it and you've already put it on there and things like that. So, a couple things that are on mine that I make sure that everyone knows regarding my health. Anywhere from an eye doctor to the chiropractor. Okay, I feel it necessary to tell you these things before you touch me or treat me. So, I have kyphosis and scoliosis. So I'm going to pretend like none of you know much about what these mean. So I'm going to dumb it down so that anybody can understand it. And pardon me if you do understand. I know there's a lot of you that do. But I want to dumb it down so that no one is in the dark here. So kyphosis is that little old lady that's hunched over and you just say, oh, well, she's that age. No. Yeah, they are that age. That is a big factor. But with us, our spines can move and contort in different ways. And one of them is this way. Another one is scoliosis. And that's a much more prominent one within the community, and it's kind of like this. So you're going sideways, and you can even have the full S. So with that, that's when they start doing spinal fusions and things like that, because it can impact your lung function, your heart, the space in your chest cavity. If your curve is over, I think it's like 40. I could be mistaken on that. But if your curve is over that, then they want to do surgery because it needs to be fixed, right? Especially if you're in adolescence, it's just going to get worse because you're growing. So, as far as nerve damage, that was in the post today about chronic pain. I have bilateral, which is both hands, medial, right here, nerve damage. Okay, so what that is it affects this, and half of this. Okay, so it's pretty much carpal tunnel. Okay, so you wake up in pain, your hand is stiff. For me, mine locks up, and especially when I'm grabbing like smaller things like washing dishes, I had to go to all plastic stuff because I was breaking stuff, because I would lock up or I would drop it or whatever because I had the weakness, and then I had the other stuff on top of it. Well, you can't really strengthen that because of the pain and everything else associated with it. So I've did a live one here before about occupational therapy, and I failed for that very reason. So that's both hands, bilateral. My left hand, I don't know, I think we're in reverse, so it probably looks like my right hand to you. Your ulnar nerve, so that's here. So that affects this other half of this finger, this side of it, and this. So I didn't start feeling that until I had the hip surgery, because still to this day I cannot lay on my right side, right? So you know how when you get up to prop yourself up to take a drink in bed and you're laying like this. Okay, I have a really, really soft bed, so that should not be an issue, especially if you're just getting up to take a drink of water. And I noticed it becoming a huge problem. My entire, it started usually around here. Will go numb. It's painful, yeah, but it's not quite as painful as this one, because once you start getting these, the main part of your hand that you use constantly, that becomes a functional issue too. You know, eating even, you use these. So for this hand, all the nerves. For this hand, these. Okay. Migraines. I've had migraines since I was born, because my mom said that I even had them before I could tell her what they were, you know. They're common with us. I can't particularly tell you why, but they're awful. You know, if you've had a migraine, you completely understand. However, like I said, I'm going to dumb it down. A migraine, you have this horrible, intense pain. It's usually one-sided. Not always, but usually. You can experience sensitivity to light, which is photophobia, sensitivity to noise, smell, taste. For me, all of that is affected. Okay, so if I'm not just sleeping, I'm in misery the entire time I have one. So I go to bed with my ice pack and try to forget the world happened. So, you know, there's proactive medicines that you can take, and then there's medicine that you can take when it happens. If you have this, you can do Botox even. That's something that I won't try because I just have this weird issue with that. But for a lot of us that suffer with migraines, we understand that you'll probably try it, right? Spinal fluid leak. For that, mine wasn't spontaneous. I had a spinal tap, and that was to check. It was in 2003, I believe. That was in to check why I was having unexplained vision loss and unexplained eye pain, which, side note, they never have figured that out. So, anyways, they did the tap. And, the protocol is you lay in bed flat on your back for X amount of hours. At that point, you should be able to not go back to normal life per se, but you shouldn't have to lay on your back constantly at that point. Well, okay, I followed the protocol. 3 days later, mind you, I've had migraines my entire life. 3 days later, I thought that my head was going to split in 2 pieces. Just a completely different pain. It was the entire head instead of just one-sided, so I knew it wasn't just a migraine. Ended up having to go back. Went through the ER this time and had to get a blood patch. So what that is they take blood from another place in your body, usually like your arm, like if a regular blood draw, and they inject it into that site that they took the spinal fluid out of, because the more that's leaking out, basically what happens is your brain, it has all this fluid to keep it in position. Well, if it starts losing fluid, then it can kind of just do whatever it wants, right? Not good. Hurts really, really bad. So that kind of leads me into the next one. And I've only read a couple articles about it. I don't think that it's one of the more researched things, but vein instability. How many of you, when you go to the doctor or the hospital or whatever, when they go to take your blood, it's an act of Congress? I mean, I really just thought that I had bad veins. My mom had bad veins. My grandma had bad veins. That's just a thing, right? Well, no. When I started doing some research into it, it definitely explains it. So basically what happens is our tissues aren't strong enough to hold that vein in place for them to draw blood. So generally what happens, I always tell them, hey, I'm a hard stick. Do they listen? No, not usually. Some of them do, and it's usually the people who have not been doing it quite as long, so they're still more open-minded. But, like, for example, my second hip surgery, I had an anesthesiologist that was doing it, and I said, okay, I'm a hard stick, and he went, oh, okay, the big egotistical comments. His face turned blood red when he had my arm all the way off the bed. I mean, everything you could possibly think of, and he still could not get blood or an IV. So I find that kind of humorous, even though it hurts like all get out. I'm sure you know what I'm talking about. That kind of thing is humorous because it's like, I tried to tell you, Some things that I've found that can help with that, and some of them the lab people don't do. Heating packs, they usually have them in the hospital. You can break them, kind of like a first aid thing. And let's say you're doing your hands, you put it on here for X amount of time, and that helps, loosen everything up and bring your blood vessels to the surface. Because if you're cold, you're harder to stick. So, and if you're dehydrated, you're harder to stick. I'm hard to stick if I drink a gallon of water. It really doesn't matter. But that helps hanging your head, not your head, hanging your hand completely off of the bed or chair or whatever, I believe helps a lot more than just the tourniquet or this. This doesn't do a thing. But 99% of the people are still going to dig. And what I mean by dig is they insert the needle and, oh, whoops, your vein moved. Okay, so then they're going to take that needle. There you go. They're going to take that needle and search for that vein and then hope that they get it. Well, if they hit it wrong, they bust your vein. Got to start all over again, and you have a huge bruise. I would rather you stick me 80 times than to dig, because digging is very, very painful, and it usually causes them to bust. That's not a huge thing, but I find it very interesting when I do get my blood taken and they look at me like I'm absolutely crazy because I'm trying to tell you, this is why I'm having a hard stick and whatever. If you throw in that vein instability, they're kind of like, oh, okay. Then they don't feel as dumb because they won't listen to you and they don't look at you like you're quite as much of a lunatic. Hang on just a second. Yes, it does. It hurts horribly. So moving on, IBS, irritable bowel syndrome, is also connected. I'm, probably TMI in this department, but I've always had issues with that on both sides. Doesn't not necessarily mean just constipation, because that it can also go the other way as well. Reflux or GERD, gastroesophageal reflux disease or disorder. Reflux, heartburn. Okay, that's also common. Osteoporosis, our bones become weaker. Like usually osteoporosis is in the older folk. Well, ours, just like a lot of things, get there a lot faster. We get arthritis a lot faster than typical public. So that's one of those. Went over it the other day. Gum recession, crowded teeth, TMJ. I have the long face, long fingers, long toes. My toes look like fingers. And hammer toes. So what hammer toe is this would be your regular straight toe for a normal person. Well, it's permanently bent. Usually it's to the side, but it can be a lot of different directions. So it'd be like that, right? It looks really funny, but you know what I'm talking about if you've seen it before. External snapping hip. Let's talk about my hip for a minute. I've had hip pain since I was probably 10, okay, over 20 years. And it's been popping and cracking and popping out of place and all this. Well, they called it juvenile arthritis forever, until I wasn't a juvenile anymore. And then it was, it's just arthritis. Well, if you've been following me, you know a little bit about my hip history, so I'm not going to go completely and delve into that. However, external snapping hip, it has to do with your IT band, which, here's the side of your hip. It's right here, along the side, along the bursa, the outside of your hip. Basically, what happens is, instead of it flowing with everything, it snaps back and forth every time you move, every time you walk. And it's usually painful, but it can also cause damage because it's not supposed to be doing that. There is a surgery to correct that, but it logically doesn't make sense to me because they cut a hole in this IT band, in this tendon. That doesn't make sense, especially if you have a connective tissue disorder, because that hole is probably just going to get bigger, right? So that to me was not something that I wanted to discuss fixing. I had a torn labrum. So your labrum, they're in your shoulders as well. That is basically a gasket that is, here's your pelvis and here's your femur. It's the gasket here. And a gasket in regular terms, that means something to keep, like in plumbing, it keeps the water from going outward, right? It helps lubricate. It helps move fluidly. So that was torn. And now in my last MRI, what was left and what was repaired is now deteriorating. Well, long story short, I probably shouldn't have had that surgery because my tissues are not reliable, right? So I saw a post on the other site actually just a few minutes ago about another person that has had a similar problem. So I'm actually really interested to see what her story is, because that's super interesting to me. Because at first they say, that's not connected. Well, let me tell you, it is. If you go on the FAI is femoral acetabular impingement. That's what it is. if you go on that site, it's full of Ehlers-Danlos people. They're a lot more common with it, probably because they're more hypermobile as a rule than we are. So if there's that many people and there's that many people having complications and failure rates, please tell me how it's not connected. You know, in general, Marfan people are not good surgery candidates. So if the doctor is not just out looking for a buck and they're actually a concerned doctor, they will probably tell you, okay, look, your risk is going to be a lot higher than Susie over here that doesn't have any of this. Okay? Our tissues are not reliable. I mean, that ranges anywhere from joint stuff to eye stuff. You know, when I had my gallbladder out, you know, they do 4 incisions. One's right above your navel, or right below your navel, rather. And he said, well, you're going to probably have a hernia because that's probably not going to heal right and it's going to protrude. I haven't yet, thank God, but I probably will. That's one of the complications that can happen to the general public, but it's not as common, right? Our skin also, we heal differently there. We do have different stretch marks. I don't think I have very many. Mine are mainly, you know, from gaining weight, losing weight, the normal stuff. But I do have a couple extra that really aren't from that. But as a rule, we can have more stretch marks than the normal person, and weird spots like across your spine and stuff. Like, who has that, right? And when you scar, it's called keloid scars. So instead of it just being like this white line, you know, maybe it's like it was this incision like this, and now it's just teeny tiny and it's white, and if you didn't know, you probably wouldn't see it. Well, ours it's almost like it looks like it bubbles up in a way, like it's swollen or something. It can be white or it can be red. I've seen both. It happens a lot with people who get the open heart surgery. They get that this whole area keloid. I have a couple of those. We talked about joint subluxation. That can be anything. You know, the people that are more hypermobile are going to experience that more. You know, some people can just do that and their shoulder pops out of place. Now, subluxation and dislocation are slightly different because subluxation goes back into place. Like when my hip pops in and out, it doesn't, as a rule, get stuck outward. I can usually get it back in with no assistance. So dislocation, a lot of people have to go to the hospital or the chiropractor or the ortho and get help putting that back in. So those are both super common. It can be anywhere from your hip to your finger. So that's something to kind of look out for. Your wingspan. Now, again, I've talked several times about how people think that I don't have it because I'm not tall, right? Well, that's true. One of the things is your wingspan being more than your height. So what that means is when you put your hands out like this, you measure from that to that, you know, your longest points, straight across. Let's say that's 54. I'm not good with math here, so we're just going to throw out numbers. That's 54. You measure your height. Well, that's 51. Okay, the general public isn't like that. So our wingspan, our arm width is longer, is bigger and taller than our height. Okay, whether it be by an inch or 5 or 6 inches. You know, you sometimes see, especially teenage boys, I've seen it the most in, that they have the real long arms. I'm trying to think offhand. I don't know anybody offhand to give you an example, but I'm sure you've seen it. They're called lanky usually. Asthma. Did we talk about that the other day? Yeah, in the sleep apnea and all of that. It's more common. You know, our our tissues in the entire body, right? They just are not reliable. To put it, that's an easy way to think of it. So when you think about your bronchus, the breathing right here, it's not reliable. Okay, so it can have a lot more damage a lot more quickly than most people. So asthma is more common than it. Not more common than the public, because obesity actually raises that as well. And if you have done any type of statistics, you know that our entire country is overweight. I'm one of them. There's most of us, right? So that does make it worse, but we have that kind of extra double whammy in there to, oh, well, you didn't have it. Well, here you go. Now you do. Murmurs are pretty common with us. Mine is I think it's like 2/6, and that's something to do with like when it happens, along like when you're reading like your EKG. There's something about the waves, and I don't know, that's too techy. But mine is really, really hard to hear. So when I go and they start listening, and a lot of doctors will kind of check off, okay, no murmur. Well, yeah, there is a murmur. You probably need to listen better, or maybe let me take off my hoodie, because there is one. You're just not hearing it because it's very, very faint. The dilated aorta. I have a real big problem with the fact that every time that I get an echo, they don't want to do the abdominal. That doesn't make any sense whatsoever to me. And if you haven't noticed by now, I am my own advocate, and I do fight for the things that I know that I need. But they still won't do that. From my research, it's more common than the thoracic, so that it just doesn't make sense to me. It's down here, your abdominal aorta, that can also stretch and bulge and dissect. Why should we look at it though? Because, but yeah, echoes, you need to get those every year. And if it's growing, probably every 6 months. Let's go into eyes. If you haven't been on my page for very long, I will tell you that is my main passion, is eyes, because I've been on both sides of the chair. So I have a pretty good understanding of it. So when we're talking about the eyes, the main thing that people have is myopia, and that means you're nearsighted. So you can see here up close, but you can't see that road sign. Okay, that is a lot more common than being farsighted with us. Farsighted means you can see that sign, but you can't really see your book. Okay, so the problem with being nearsighted or myopic, it raises your chances of retinal detachment. I think it was like 10-fold. That's huge, okay? A retinal detachment, the retina is the back lining of your eyeball, and that's what does transmission and a lot of really important things. Your macula is there. You hear about macular degeneration. Well, your macula is the part in your retina that focuses. It's like your best vision sight, right? That's also there on your retina. So if you start having peeling or damaging, or mine is swollen in some parts and then thinning in other parts. That doesn't really make sense to me, but that's the lovely joy of our body. But retinal detachment is more common in us, period. And then you multiply that with somebody who's myopic, nearsighted, and that chance goes up even higher. The more nearsighted you are, so meaning the less you can see down that eye chart, like if you can only see that big E, if you're legally blind, you can only see that, you're more myopic, and your chances are more of getting that retinal detachment. Of course, it doesn't help if we have eye surgery, because every time they go in there, they're weakening tissues, whether that be the corneal tissues, the front covering, or the retina. So I've told this story on one of my eye-related lives before. When I went to get my last eye surgery, I was getting my right lens repositioned because the stitches, the lifespan is like 10 to 15 years, so these two broke. So my lens was kind of just like flopping, just hanging out in no man's land, right? So we thought that was the reason for my unexplained eye pain and unexplained vision loss. Well, long story short, it wasn't. But they told me, you've already had two very big eye surgeries in that eye. So the risk of a retinal detachment or a retinal tear is huge. Thankfully, I was at Duke, and I really, really, really trust them. And my doctor was actually the same doctor that took my lenses out when I was 4. So I trusted him a lot. He was smart enough to bring in a retinal specialist. So in the event that would happen, he wouldn't have to get on the phone and call somebody and say, hey, get over here. No. He was already scrubbed in. He was already there. He was already ready. So that's something very important to note. If you are going to have eye surgery, that you've maybe had several before, ask about that, because maybe they haven't really thought about it. Our chance is higher. You've went in. You've done it before. What's it going to hurt to say, hey, what do you think about having a retinal specialist? So if it would have torn or detached, I would have had to stay in North Carolina, because I'm in West Virginia with lots of hills between here and North Carolina. I would have had to stay in North Carolina because I couldn't do elevation change for a month. They would have done, I think there's a couple different types of the bubbles that they can put in there to fix the detached retina, kind of like push it back into place, if you will. I was going to get the gas one. So I would have to lay face down for a month. I mean, obviously I could go to the bathroom and change clothes, take a shower, but then basically go back and lay down, because the more elevation change, even as far as laying to sitting straight up, it's going to make a difference. So thankfully I did not have to do that. But that's something that I always have to keep in mind for my next surgeries, because, I mean, stitches have a limited lifespan. I have implants. This one, since I had the surgery in 2013, that one's probably good for a little while. This one, these are stitches from 2001. So, I mean, I'll just go into a little bit of the issue that I have with this. If stitches are going to break, they have a limited lifespan, why would you not go under controlled environment and go in and either replace the stitches or add a couple more stitches? Doesn't make any sense to me whatsoever why they are unwilling to do that, because if that breaks, not only will I go back to seeing color and light only, like I can't tell you who you are from here, but it will be a huge trauma inside the eye, because instead of just clipping that, it'll do that, right? So that's almost guaranteed a retinal detachment or tear. So that's kind of still my goal. I still try to, why don't we go under controlled, because they're going to break, whether it's today or in 20 years. That's just how they work. So they're not made to last forever. So, enough about that. Iridogenesis. So, there's a difference between that and nystagmus. Nystagmus is when your entire eye does this, right? Iridogenesis, it almost looks like just your iris is doing that, just the colored part. It does it more if you don't have lenses. If you're aphakic, it does it more noticeably. It does it less noticeable than aphakic, but more if you have implants. Does that make sense? If you have implants, it does it more than the normal eye, but it does it more than that if you are aphakic. I'm hoping that made sense. Anyways, what it is it looks like water swishing around when you move your eyes, usually when you can see it. And the reason for that is that's usually where your lens would be, and your accommodating, expanding, moving, changing lens would be. And if you don't have one, or if you have a artificial one like I do, it's not stabilized as well, because that your eye itself is 1 inch. That's all. It's not a big organ at all. So if you take out the largest central object, it's going to be weakened, right? So therein it causes this flutter, if you will. Now, I've heard a lot of different perspectives on when to get implants versus just being aphakic and wearing glasses. And the thing that I will tell you, yes, if you get implants, you very well might have to get repetitive surgeries, like I was saying about stitches. However, if one day you decide that you do want that surgery, the longer you're aphakic or without a lens, the weaker your eye as a whole will be. So that is called amblyopia. So basically, no matter how hard they try, you cannot correct your vision to 20/20. Just doesn't happen. I have that in both eyes. And I only recently, probably in the last 2 years, fully understood why that was. It makes perfect sense now. There wasn't this stabilizing mechanism in my eye to make it strong and to let it grow naturally. So it kind of just did what it had to do, and that was all, right? So the longer you're aphakic, the harder it is to get your prescription correct later on. Okay? Iris transillumination. So your iris is the color part. Transillumination means that you can see light through it. I talked about this one before too. I think it's very interesting. Of course, I'm an eye nerd, so maybe it's just me. I think it's very interesting. You can't see it with the naked eye, as a rule. You can see it through the slit lamp. It's extremely neat to see. It looks like it instead of light just reflecting back through your pupil, it's coming back through your iris, kind of like a sunburst. So it's really neat to see under the slit lamp. But I have this theory, it's largely caused to surgery. You go in there, you cause more damage. The eye's only 1 inch big. You start scraping, you lose some iris, you lose some color, you lose some pigment, right? That's not the only thing that can cause it. Of course, there's albinos that have never had eye surgery, right? But that is a large contributor. I think that it'll be really, really interesting, because each time I go back to the doctor, it's gotten worse, right? It probably will never happen, but I think it would be really cool to be able to see it with your naked eye. Granted, you'll need sunglasses even more than you already did, but it just sounds really neat to see that, right? Probably not good for you at all. But again, I'm an eye nerd. So that's kind of the main gist of what I have written down here that, we've already posted about through the month. It's the 13th. And what I have in relation to that. That's not everything, I have this huge list. But it's kind of the main idea. So in this binder that I'm telling you to take with you, these are your medicines. Now, don't just put losartan. Okay, well, what milligram are you on? It could be 50, it could be 100. They don't know that. How many times a day do you take it? Do you take it 1 or do you take it 3? Very, very important. So you want to put your milligrams and your frequency. And if it's as needed, like my migraine medicine is as needed. Well, generally you would say, oh, well, I'm not taking that every day, so I don't need to put that on there. Wrong. Because if they're prescribing you let's say the losartan, that could have a drug interaction with your ProAir or with your Phenagrin. And they don't know that you're on it. So how are they going to know this drug interaction? Yes, the pharmacy should catch it and not allow that to happen, but they're busy. You know, mistakes get made, it gets pushed past, it happens. So you need to write down anything. If you take a leave more than a few times a week, you should probably mention that. On here also, you want to add your drug allergies. Also super important. If you do not have drug allergies, make a note of that also. And down here, it's your emergency contact. Because if you find me with this binder, you can look through there and say, oh, okay, I need to contact her mom at, then her name, and then her phone number. Make life a little bit easier for that person that's freaking out after they found you. Right? And then also, there in the corner, I put when the last time I updated that list was. And that's solely for my purposes so that I know how up to date it is. On this next page, I have doctor information. Most generally, you won't need that, but if you need your PCP, your regular primary care doctor. As a rule, almost everybody says, oh, okay, who's your primary care doctor? And you say, yada yada. Okay, well, do you know his number? No. Sometimes you'll have it in your phone, sometimes you won't. So, in order to evade all of that searching and wondering and questioning, have it written down. I have, the name of the person, what they do, and then their phone number. Makes life a lot easier for everyone. Then you have surgeries. So on this page, I only put my main surgeries, 5 eye surgeries, gallbladder removal, 2 hip surgeries, and wisdom teeth cut out, and gum surgeries. I don't know if I said that. That's the stuff that they need to know 100%. Okay? So you need to have that down. I recommend having the year that it was done, preferably the exact date, but that doesn't always happen. I can't remember in 1990 when exactly they took my lenses out. So as long as you can get the roundabout, that gives them an idea. Let's say you're at the eye doctor and you say, I was aphakic from 1990 to 2001. Well, that gives them a better idea of what they need to be looking for, right? I also include what age I was because my birthday's in July. So half of that year I was 15, half of it I was 16. Is that super important? Probably not, but I'm a little bit anal retentive in this kind of thing if you haven't noticed. So I have written down, with my hip surgeries, there's lots of things that they did. I need to write them all down because when they ask me, I might not remember that they debrided or that they did a major removal of dead tissue and cleanup, and that's not stuff that immediately pops out, so I need to write that down. If I go to another ortho, maybe not my eye doctor, he probably doesn't care, but another doctor may really need that information. So moving on this next page, I have diagnostic procedures. So with that, that would be more so for your specialists. So for that, I have, spinal tap. I had tear duct plugs put in, mammograms, colonoscopy, endoscopy, bladder installations, blepharotomy. I think that's all. Those are important. If you go to your gastro doctor and they want to know, hey, have you ever had an endoscopy? Yeah. Is that all? Like, when did you have it? Why did you have it? How many have you had? Very important. You'll probably not remember it. I actually had forgotten about my tear duct plugs for years until I was going through those records one day and I thought, Well, I probably need to write that down because obviously I'm forgetting it. So for me, that's the main part of your binder that you need to have. Let me see if I can turn this around. I have tabs. So like my main one, HPI, is history and present illness. So that's where I have all of the stuff that I just went over. Eye, cardio, skeletal are my three main Marfan contributors. So those get their own section. And those, like under eye, it goes from anywhere from testing to, well, doctor's notes. Same with cardiology. Testing, somewhere in here is doctor notes. I even have PT stuff because that's under skeletal. So, I'm hoping that this little tour and explanation has helped you, because it is a huge factor in being your advocate, being your own advocate. So, something that I also like to preach, if you will, get your records, because I can tell you 100%, I worked in the healthcare field. I did it. Was it by malice? No. It was just by, I forgot, or I didn't tell you had iridodenesis, because most people don't know what it is. Most people don't care what it is. Does it affect me? Does it hurt me? No. Okay, well, why would I worry you? So it's kind of almost in the medical mind, you're doing them a favor. You're giving them less to worry about. But on the contrary, I've had testing come back and the doctor never ever read it. He couldn't have, because there was stuff in the report that was completely blatant changes or problems, be it an x-ray or an echo, completely blatant changes, and you just said normal. I mean, and I'm not saying that my doctors are any more common to do it than yours, because they're busy also. We talked about the pharmacy being busy. The doctor's busy too. So when he sees your x-ray come across his desk, he's like, okay, she's not dying. She's not dying. That sounds really silly, but I mean, that's what happens, honestly. Hang on. Okay, yeah, absolutely, sure. She asked for a list of everything I'm covering. I'd be more than happy to do that for any of you, because it is super, super important. I mean, I don't even care to help you build your binder, because I'm that avid about it. Okay? My mom has always thought that was really silly, until she needed something from 5 years ago, let's say. And she was like, what was that? And I'm thinking, well, I don't know either. Can you tell me your doctor? Who did it? Okay, well, it was Joe Bob. Okay, well, let's go to Joe Bob's office, because they are mandatory required to keep your records for 7 years. Okay, let's go to Joe Bob's office and get your records. You have to sign a release. They can charge you if they want to. Some don't. It depends on how much they're printing and if they're mailing it to you or not. So let's go to Joe Bob's office and get this. Well, come to find out, it may have been something important. I'm just giving you an example off the top of my head. Could have been something important. Maybe you had a colonoscopy and your gastro is really wondering what it said. You had polyps and you don't remember. Polyps can be cancerous. They're not always, but that might be something they want to know. So, get your records. You can go back, like I just gave the example, write down all your doctors, and go back and call each one of them and say, hey, I need my medical records from this date to this date. or just, I need all of my medical records. They cannot, I repeat, they cannot tell you no, because those are yours. You have an absolute right to your medical records because they are yours. I'll repeat that. They are yours. They cannot say no. That being said, they can charge you, and they can take up to, I believe it's 3 months. So even if it's one piece of paper, if this doctor's office isn't a big fan of doing that, they can take up to this, let's say 3 months, I'm not positive on the time limit, to print this one piece of paper and send it to you, and then charge you for sending it to you and for printing it. I don't really think that that's fair, but that's how it is. Something that I do that kind of helps me deter that cost and that issue is each and every single time I check out, I say, you know, they give you your next appointment, you have to pay your copay, whatever. Okay, have a nice day. No. And again, most of my doctors probably hate me because I am the pain in their side. That's okay. I need a summary of today's visit. Some of them will look at you and be like, huh? Summary? What are you talking about? And I've had people give me like the billing sheet, like what the diagnosis code was. Well, that helps me, but does it help you if you don't know what the CPT codes are? No, you don't know what the CPT code for iridogenesis is. So, yeah, you can look it up, but most people will just say, oh, well, this is trash. So, whether they, almost, I would say 98% of doctors now do their own medical records charting. Maybe not necessarily while they're in the room with you. Depends on the doctor. But most of them are online or are in a database. That makes life a lot easier. You know, number one, you can read what they're writing. That's a huge difference because I worked with doctors and my writing has gotten, it was always bad because I hold my pen wrong. I can go into that at a different time, but it's gotten worse. So that's helped be able to actually understand what they say. They can have someone do dictation, so they're over there filling it out for them. I say all of this because they may or may not have it ready when you check out. It would be extremely easy to say, okay, cool, go home and forget all about it. So instead of doing that, what I do, and I encourage you to do, is, okay, about how long does it take them to dictate? And if they say 3 days, okay, well, I'll call you back in 4 days. Do I need to sign a release so that you can mail that to me? Because sometimes you run into those doctors that HIPAA regulations, you should have to sign one. You should. Sometimes you run into people that don't require that. And for the patient, that makes life a little easier. So if they do require it, you want to go ahead and ask so that when you call, they don't say, okay, I have to mail you this release, and then you sign it, and then you mail it back, and then I can send them to you. Skip that step altogether and say, do I need to sign a release so that you can mail them to me? If the answer is no, yes, whatever, get it done. 4 days later or whenever, call back and say, hey, this is so-and-so. I need to get my summary from the last visit. Can you mail it to me? Usually it's not a problem. Some of them make you go pick it up. Still, that record could be potentially life-saving. Depending on how busy your doctor was or how much he glanced over it, it could save your life. Will it usually? Probably not, but let's say you have a really bad kidney infection and it didn't grow initially in their dip, but it grew later. Well, the doctor, he only looked at the dip and said, there's nothing there. Why do I need to look at that? Well, that kidney infection almost certainly will get worse and will cause more damage. So that needs to be taken care of immediately. If it says it in your report that you have a kidney infection, you should probably know that. Sometimes, like I said, they're too busy. I'm not going to say that they're not paying attention, but they are busy, and that could get brushed over. You need to know. With me, I have several different binders. I have this one. So basically, when I was going to go to Vanderbilt, I was going to send all my own information. Let's expedite this process. Instead of you contacting 15 doctors, let me send it to you. It costs like $35, but that's okay because they got it in order, coded, highlighted, done, right? So that's this book. I have a book probably that big just for eye stuff because my main issue has always been eyes. So every single test I absolutely must have. It's not like a urine test that I might brush over. No, not going to happen. I have groups together like gynecology and urology. Well, that's along the same guidelines, so I put those in the same book. So that way I don't have to take every book with me to go to the urologist. I can take the urology book and not come in with an entire backpack full of stuff, because I usually do. And one thing I will also extremely encourage as being your own advocate, make a list. And there's a lot of different reasons for that. And I think the biggest one is if you're going and you're going to get, even if you're not prepared for it, and you get any type of shocking information that maybe you hadn't completely digested yet, you're going to completely forget everything that was in your mind that you needed to ask him. Because now your mind is thinking, oh, well, what about this, completely forget about your back hurting and you needed this, and this because he's distracted you. Even not in that case, you can be forgetful. I'm very forgetful. So if I don't write it down, we probably won't talk about it. So I write down everything from what tests I had to when they're due again. Okay, doc, this is happening. Why is this happening? Okay, doc, this has changed. Not that I need a test or a medicine or this or that, but it's changed, and I need you to make note in my record that has changed. Okay? Stuff that you're not going to remember. Hey, my last mammogram was March. If they didn't ask you and you didn't write it down, you probably won't know that. Your primary care doctor probably needs a record of that. So make a list. Take it with you. Take a notepad with you if you need to answer these questions and write them down. If you can't remember it, do it. Ask him to repeat it. I mean, the thing is here, they work for you. You are their boss. Now, they can fire you as a patient, and I've been fired on more than one occasion, but you most certainly can fire them as well. So it's kind of a give and take. You don't have to accept mediocre treatment and mediocre care and a doctor that won't answer your questions. You don't have to accept that. So don't. You don't have to I don't remember where I was going. Brain fart. Anyways, the appointment time. If you need to talk about 25 things and he says, oh, well, I only have time for 5, well, that's not acceptable because you work for me and I have 25 issues. Sometimes that results in a not so happy doctor, but so be it. You're paying, or your insurance is paying, a very hefty fee for his what could be 2 minutes or 25 minutes. If you can't get everything out in 2 minutes, which I don't know anybody that can, you keep going, because he's getting paid. Do not think he isn't, because he is. And just like everybody else, he can work for his money, do his job, be thorough. They get a lot of breaks for the people that aren't sick. You know, they can go in and say, okay, Miss Jones, you're I'll see you next year. So, you know what? That just bought me some time to tell you what's going on with me. Again, your doctors might not like you very much. You might not be buddies, but that will help you get better, more adequate care. Food for thought. So, I am sure that I've probably forgot some stuff, and be more than happy to answer questions, or message me, share this. I don't think that 5th time I could actually say that correctly, but share this. Because it could help somebody. It could help somebody with diverticulitis that doesn't even have Marfan's, because they still need a record of all the tests that they've had. So share it to your page. Share it with your mom. Share it with your best friend. Please. I spent way too much time going through all of my records because I hadn't done it, and I had to sort them and put them in this pile and that pile. Don't do that. You can, and you probably will have to in the beginning. Don't continue to do that, because it is so much easier to come home with your echo report, put it in a clear, because I have all of mine in clear things. You don't have to, but it's easier. Put it in a clear thing and file it under cardio, so that next time you need your echo, you go to cardio, boom, there it is. Save yourself some trouble. Go ahead, get your records, make notes, research. If you don't want to research, contact me and I'll gladly do it for you, because I'm quite a bit of a nerd. And I really enjoy doing that kind of thing and helping others. You know, I don't get on here and tell you about my problems to get pity or to complain or anything like that. Not anything. You know, I have this theory that if I've already been through it, why would I not help somebody else? Right? I've already been through 5 eye surgeries. So if I can help you maybe push that eye surgery back, if at all possible, why would I not do that? I don't get on here to ask for pity. So if that's what you maybe have thought before, you are wrong. I get on here to help you, to help anybody that's willing to listen, because I've been through it. I've already struggled, cried, whatever, overcame it. I'm here still. Let me help you.